Hello, my name is Terry Middlebrooks, and I work in the Department of Interprofessional Practice and Training, known as the DIPT department. DIPT focuses on advancement of knowledge. This department works on collaborative practices across all disciplines to see how we can improve the system to provide best practice care to all patients. One specific area of care is geriatric care. One of our goals is to hardwire age-friendly care that you have already learned is best practice for geriatric patients. We want all disciplines to understand what the best practice processes are so that these processes can become standard care. In the previous lecture, you learned of the age-friendly health system movement. You learned why we need this movement, because the population is aging, because they're more at risk when they come to the hospital. You learned that this number of patients is growing and how standardized care practices are needed. You learned that age-friendly care, best practice care for the elderly, is evidence-based, causes no harm, and aligns with what matters to older adults and their caregivers. You also learned that key leaders in geriatrics have packaged 4 core concepts that you need to think about when caring for an older adult into a framework known as the 4 M's. What matters, medication, mentation, and mobility. You'll be learning more on each of these 4 M's as we continue these lectures. While all 4 M's work together, today we're going to focus on what matters and medication, these pieces of this framework. Our biggest opportunities are in the umbrella of what matters. As we continue to hardwire these processes, we still need to learn and focus on what matters to each patient, as this is the cornerstone of the 4 M's. What matters is defined as knowing and aligning care with each older adult's specific health outcome goals and care preferences, including but not limited to end-of-life care and across all settings. When we as healthcare providers know what matters, what is important to a patient, we can use the other M's to create goals and plans. Because you see, each person is unique. As we age, we accumulate more conditions. We have different social and cultural beliefs and life experiences that drive what's important to us. What is important to us can change over time or during a certain event. Knowing what is important to each person as an individual and understanding how what matters relates to a patient's health goals is necessary to provide person-centered care that is best practice for patients. As you look at this slide, you may think that the group that's younger appears more diverse. Actually, the older group is what has more differences. You as a nurse need to understand this. The aging population becomes more and more different as they grow older. They have more comorbidities. They have different diseases. Some of them are healthier than others. This is known as being heterogeneous. Each person you encounter is a unique individual with their own unique goals. What matters vary from person to person. And we need to recognize this as the center of the 4 M's. When we understand what matters to a patient and their caregiver, we can understand and base our care plans around what drives them, what they want to accomplish, what they want to be able to do. Then we need to look close at the other M's and make sure that the medications we're given or the ones we are not giving to a patient do not interfere with what matters. We want to understand their mentation so that we can understand their goals. We need to prevent delirium. Delirium can interfere with what matters to a patient. We want to keep the patient mobile so they can achieve what matters. We do not want them to receive medications that can contribute to falls or functional and cognitive decline. We need to make sure we manage their pain so that they can move, so that they can do what matters. All of these M's work together, and you, as a nursing student, can make sure you're asking questions of the patient that lets them know you value them as a part of the care plan. Things that you can do to find out what matters is to engage with your patient, spend time with them, listen to them, ask them questions. You can ask them questions like, what are your health goals? What matters most to you today? What matters to you about your health so we can make sure our goals are aligning with your goals? Is anything bothering you today? What are some of the things you're looking forward to doing? What is one thing about your health care you most want to focus on so that you can do whatever it is more often and more easily? When you know what matters to a patient, you can use this. You can use this to guide their treatment plan and their goals. Think about how what matters affects the other's M's. If the patient wants to go home, then they need to move. If they want to move, they need to be getting the right kind of medications. We don't want their mentation to affect their movement. We don't want their mentation to affect what matters to them. We want to share with the care team what matters to the patient. We want to write what matters maybe on the whiteboard. We want to use what matters to motivate this patient. And we want to use what matters to empower the patient. In summary, all individuals can vary in what matters. What matters can motivate a patient, and spending time with a patient to find out what matters can help you create a person-centered plan, a plan that's specific to that person based around what matters to them. You see, the 4M's framework begins and ends with what matters.
Hello, my name is Courtney Hall, and I work in the Department of Interprofessional Practice and Training with Terry. As you've learned in previous lectures, in 2016, the John A. Hartford Foundation and the Institute for Healthcare Improvement set out to improve care for older adults. They created an evidence based framework called the 4M's that could be used for all patients to help providers give the best possible care to this growing and vulnerable population. In this section, we're going to talk more about the medication piece of this framework. Age related changes can affect the way our bodies process and respond to medications, which can lead to an increased chance of medication side effects. Medications, as we know, can be life saving, but taking too many can cause unnecessary problems. So, what we want to remember is if medication is necessary, use age friendly medication that does not interfere with what matters to the older adult, mobility, or mentation across settings of care. Older adults are at risk for polypharmacy due to an increase in various chronic health conditions. Many older adults see more than one doctor, and each doctor may prescribe medications for a certain condition without being aware of everything else that the patient takes. This creates an increased risk for drug interactions, adverse drug events such as falls and cognitive impairment, and noncompliance. This also puts patients at an increased risk for prescribing cascade, which is the patient takes one medication that causes a side effect, such as headache. Well, instead of getting to the root cause of that headache, another medication is prescribed to treat that headache, and then that trend continues. Inappropriate polypharmacy also creates a burden for patients and their families because for each medication that's prescribed, the patient or caregiver has to understand why it's been prescribed, any potential side effects to look out for, and then they also have to figure out how to manage taking that medication at the appropriate time each day and to contact their doctor when they need refills. It's important to gather an accurate medication list from your patients and make sure that this includes any over the counter medications that they're taking, any recreational drugs that they partake in, and alcohol use. On this slide, I've listed 7 drug categories, examples from each category, and possible adverse effects of each. I want to bring these categories to your attention so that a red flag goes up in your mind when you give these drugs to patients or when you see these drugs in your practice because they could have an effect on your patient's mobility, mentation, and potentially what matters. There's a QR code in the top right corner that could take you to an extended list of medications to be aware of called the Beers criteria. So this is a great resource to have, and you'll see under the right-hand column under possible adverse effects that these medication categories can affect your patient's cognition. They can put your patient at increased risk for falls. They can cause delirium, fractures, and these are all things that we want to avoid in this especially vulnerable population. A comprehensive pain management plan should be individualized to the patient, and it should include both non-pharmacologic and pharmacologic therapies. So this starts with an accurate assessment. And here on the right, this is a picture of the pathway for assessment and management of pain in older adults that we use here at UAB. So it shows you how to assess your pain, perform a comprehensive assessment, provides you with an acronym to use for a treatment plan. It does have medication categories based on severity. And then a key point for older adults 65 and up is that everyone must poop. And any patient on scheduled pain medications may also need to be on a stool softener. This is the acronym I was talking about called I Am RID, and it will help you to come up with a pain management plan individualized for your patient. So the first I stands for interprofessional team. This is your physicians, your RNs, your patient care techs, chaplain, therapy services. It could consist of arts and medicine and pet therapy. The A stands for assess any possible causes like constipation or urinary retention. A lot of patients get joint stiffness from being in the bed all day. The M stands for mobilize. Mobilization can help many types of pain in the hospital. We try to get patients out of bed up to the chair at least 3 times a day with their meals. R stands for reposition at least every 2 hours if the patient is in bed. I stands for ice and heat pack. And then D stands for distraction or emotional support. You can use their visitors or family members for this. You can use help volunteers, arts and medicine, guided imagery on your care channels on the patient's TV. You can use objects from the delirium prevention toolbox. Or if you find out your patient enjoys reading or working through crossword puzzles, this is a great opportunity to kind of get them doing what they're used to doing at home to distract them from their pain. So in summary, I just want you guys to recognize that older adults are at risk for adverse outcomes from potentially inappropriate medications. I know that as nurses, we don't prescribe these medications, but we are able to advocate for our patients when we see these medications being prescribed. It's important to gather an accurate med list from your patient so that the care team knows what the patient is already taking, and take the time to perform a thorough pain assessment on your patient. This will allow you to make an individualized plan to take the best care of your patient while keeping in mind what matters most to them while you're setting goals. Thank you.